This is a review not only of kind of the highlights from San Antonio, but also we've retitled that, as you noticed, the year in review. And I think that's really important because San Antonio, yes, may be at the end of the year, but there's also some really great highlights that have happened throughout the year, so we want to be able to pull that in. As you will see also, we do try to bring some of the best and brightest speakers to Kansas City. I think it's important for us to hear from subject matter experts where we can collaborate and really learn from their experience as well. So we have about 5 hours of jam-packed information. The highlight for us is also always the case studies. So we hope that you're very interactive as usual. It's a great way, in my opinion, to also see sort of some discussion between experts and yourselves who are seeing patients every day in clinic. So that's really, I think, a highlight of this program. So we will begin with our first speaker. And Dr. Cobain, do you want to join us up here? There you go. Thank you. And Erin Cobain is an associate professor of internal medicine in the Division of Hem/Onc at the University of Michigan Ruggell Cancer Center, and she serves as the co-chair of the breast cancer clinical research team. We are excited to welcome her, and she's going to be discussing systemic treatment of stage 1 hormone-negative breast cancer, optimal regimens, timing, and duration. So thank you so much, and we'll turn it over to you.
Great. Thank you very much. Good morning, everybody. Pleasure to be with you this morning. It's my pleasure to talk a little bit more about the systemic treatment of stage 1 triple-negative breast cancer. This is actually an area where probably haven't seen a lot of new data in the recent years, but I think given all of the changes that have happened in the recent years with regards to how we treat stage 2 and 3 triple-negative breast cancer, certainly worth revisiting this topic and just understanding the distinction really with regards to how we treat this entity. These are my disclosures. So just as an outline, I'm going to do a brief review of the current systemic therapy treatment paradigms for early stage triple-negative breast cancer in general. I then want to review a few case examples, specifically a case of neoadjuvant systemic therapy for a patient who presents with clinical T1N0 disease. And then I also want to talk about a case where there's adjuvant systemic therapy decision-making for the patient with clinical T1N0 disease that proceeds to upfront surgery. And then we'll wrap up with some concluding thoughts. So I think all of us now are very familiar with the treatment paradigm for really clinical stage 2 or 3 triple-negative breast cancer, which as a result of the KEYNOTE-522 clinical trial has established that combination chemotherapy and immunotherapy clearly has a role for these patients. So again, patients that are clinical T1 but have nodal involvement or clinical T2 with any nodal, either N0 or nodal involvement, are treated with neoadjuvant systemic therapy that involves adriamycin, Cytoxan, Taxol, carboplatin, and pembrolizumab. And then after that neoadjuvant therapy, when they go on to surgery, the adjuvant recommendations are really geared toward and determined by whether or not those individuals have residual disease present in surgery. So if they have residual disease and they have a germline BRCA mutation, these individuals then go on to continue immunotherapy with 9 cycles of pembrolizumab, and they also get targeted PARP inhibition with olaparib. If they are germline BRCA wild type with residual disease, they continue their immunotherapy with pembrolizumab and also receive capecitabine. And if they have a pathologic complete response, generally patients who we think have exceptional prognosis, they, as our current standard of care, go on to just continue 9 additional cycles of immunotherapy. So again, this is the KEYNOTE-522 clinical trial. Again, this is stage 2 and 3 triple-negative breast cancer treated with combination chemo and immunotherapy. And what the KEYNOTE-522 trial established for us is that those who received immunotherapy had an improvement in the likelihood of having a pathologic complete response at time of surgery comparatively to those patients who had chemotherapy alone. And that was actually regardless of PD-L1 status. So we're used to seeing PD-L1 as a biomarker that's predictive of immunotherapy benefit in the metastatic setting, but at least in the early stage disease setting, PD-L1 did not appear to be predictive. I also want to highlight the Kaplan-Meier curves at the bottom. On the left, you'll see the event-free survival analysis for all patients, again, clearly favoring the chemo-immunotherapy combination over chemo alone. But what I think is really remarkable as you look at the Kaplan-Meier curve to the right are that those patients who have a pathologic complete response at time of surgery, regardless of which arm they were assigned to, actually have an exceptional prognosis, generally with an event-free survival that's over 90%. So again, this ultimately resulted in the approval in 2021 of pembrolizumab for the treatment of stage 2 and stage 3 disease. So, what about clinical stage 1, triple-negative breast cancer? I think a basic principle is that chemotherapy is warranted in most circumstances to decrease the risk of recurrence. And also, I think important to note, in this setting, there is no clear role for immunotherapy. Questions we often pose when we're seeing these patients clinically. Which chemotherapy regimen is preferred? How important is the anthracycline? Should all of these patients be receiving ACT chemotherapy, our typical gold standard chemo? If we're not going to give anthracycline and we're considering Taxotere Cytoxan, should we be giving TC ×4 or ×6? When should we actually consider a platinum? There may be times when it's very appropriate to actually consider Taxotere carboplatin. And when should platinum be considered, and how might we better understand whether or not even platinum-based regimens might replace anthracycline-containing regimens? Which patients that have clinical stage 1 disease should receive neoadjuvant chemotherapy? And can we safely eliminate chemotherapy for patients that are very low risk? So I just want to show us our NCCN guidelines here and just highlight a few things of note. So for patients that have surgical treatment for what appears to be a stage 1 triple-negative breast cancer and are T1A, so a tumor that is under 0.5 centimeters in size and N0. In general, these patients have an exceptional prognosis and no adjuvant systemic therapy is recommended. However, if the tumor is T1B or T1C, or if there is any nodal involvement, certainly for these patients, we are at least considering adjuvant systemic therapy, specifically adjuvant chemotherapy. And again, throughout this discussion, we're going to launch into what some of those considerations are via some case-based examples. So I think many of you are familiar with this analysis from 3 large trials, helping us understand what is really the role of anthracycline treatment. The Kaplan-Meier curve, of course, on the left is not just exclusively limited to those patients with triple-negative breast cancer. This is looking at the value of anthracyclines in all cases that are HER2-negative breast cancer, so it included hormone receptor-positive as well. And what you can see is that, indeed, there is a small benefit to anthracyclines. There's about a 2 to 3% difference favoring anthracycline-containing regimen over TC, Taxotere Cytoxan. I do want to highlight that in the context of these 3 trials, the Taxotere Cytoxan comparison here is Taxotere Cytoxan ×6 cycles. And then as we look at the subset analyses, you can see from the forest plots here that for patients that have hormone-negative breast cancer, there clearly does seem to be a benefit of anthracyclines. When you look at the plot, it's favoring the anthracycline use. And then again, as you look at the nodal involvement, of course we have to be cautious in the triple-negative group because these are smaller numbers. Again, it seems to favor the anthracycline across all groups, although perhaps that's maybe a little bit less pronounced for those without nodal involvement. I think also really important to note that there have been smaller studies that have demonstrated similar outcomes in early stage triple-negative breast cancer with platinum taxane regimens versus anthracycline-based regimens. So on the left, we see one of the graphics from the NeoStop trial. So this was led by Dr. Sharma, and it's neoadjuvant carboplatin paclitaxel followed by adriamycin Cytoxan versus carboplatin docetaxel for 6 cycles. And what you can see is that the likelihood of achieving a pathologic complete response at time of surgery, as well as residual cancer burden, is really equivalent between these two regimens. And indeed, this data is actually the basis of the SCARLET clinical trial, the NCTN trial in clinical stage 2 and 3 disease, that's attempting to de-escalate the chemotherapy backbone to help us understand, actually, can our patients with triple-negative disease avoid an anthracycline entirely? So I think as we treat patients with stage 1 triple-negative breast cancer, it's probably fair to ask this question as well. Another study looking again at an adjuvant platinum-based regimen, adjuvant epirubicin, cyclophosphamide, docetaxel, or paclitaxel versus carboplatin with a taxane. Very similar disease-free and overall survival. So the limited data that we have from these smaller studies suggests that there might be several patients that do not require an anthracycline. We get asked this question actually in consults all the time, for patients that we are going to give an anthracycline sparing regimen and we're considering docetaxel cyclophosphamide, should we be giving TC times 4 or TC times 6? And we don't really actually have a firm answer to this question. Docetaxel cyclophosphamide times 4 has been compared to AC times 4. Of course, that was not AC, not with a taxane. And TC times 4 is indeed superior to AC times 4, which is where the TC times 4 regimen comes from. But there really hasn't been a prospective randomized comparison of TC times 4 versus TC times 6. Again, we talked a little bit about this in the beginning with regards to the NCCN guidelines. Can we safely eliminate adjuvant chemotherapy in patients that have very low risk triple-negative breast cancer? This is from a fairly recently published analysis of SEER data in NPJ Breast, looking at if you have patients with triple-negative disease that are T1-MYC or T1A, they have excellent outcomes, really, without adjuvant systemic therapy. You can see that really the curves of those patients who received adjuvant systemic therapy versus those that did not have really overlapping outcomes. Even with T1B disease, it's really a subtle difference, and then T1C is really where you start to see there's a very clear separation in outcomes favoring the use of systemic therapy with chemotherapy. So I think with the rest of the time we have, I want to go through a couple of case examples that I think highlight some of these decision points and are important issues that we face in clinic every day. So the first case is a 37-year-old, otherwise healthy woman. She comes into her primary care physician and has a new palpable left breast mass. Diagnostic mammogram and ultrasound identify a 1.8 centimeter spiculated mass in the region of palpable concern, highly suspicious for malignancy. She ultimately undergoes a core biopsy, which is consistent with invasive ductal carcinoma that is grade 3, triple negative. And this patient, importantly, undergoes axillary imaging, which I do want to highlight. I think for patients with triple-negative breast cancer, very important that we're assessing the axilla with imaging so that we understand if they are potential candidates for neoadjuvant immunotherapy. Her axillary ultrasound is unremarkable, and her clinical exam suggests that she is clinically node negative. So here we have this patient who comes to the medical oncology clinic. Again, she's 37 years old with a clinical T1C N0 triple-negative breast cancer. I think, in my opinion, this patient is actually an excellent candidate to consider neoadjuvant chemotherapy with ACT. A couple of reasons why. So this patient is unlikely to experience significant toxicity from an anthracycline, being young and otherwise healthy. There is also the opportunity then to subsequently pursue adjuvant systemic therapy if this patient has residual disease, and also the opportunity to complete genetic testing for this patient who is young, has a reasonable pretest probability of having genetic susceptibility to breast cancer, which would allow time for surgical decision-making, as some patients who have germline cancer susceptibility may actually consider bilateral mastectomy as their surgical treatment. So speaking of the opportunity to give adjuvant systemic therapy for patients who have residual disease at time of surgery after neoadjuvant systemic therapy, I just want to review our data from the CREATE-X clinical trial. This is the study of patients with stage 1 through 3 HER2 negative breast cancer, all treated with neoadjuvant chemotherapy, and if at surgery they did not have pathologic complete response, they were randomly assigned to either their standard therapy versus adjuvant capecitabine. And I'm highlighting here the results of that study for specifically the patient population that had triple-negative disease, demonstrating that there was indeed a disease-free survival benefit as well as an overall survival benefit among patients with triple-negative disease, favoring adjuvant capecitabine over observation for these patients. So again, these patients that have T1C N0 disease that clearly merit chemotherapy, if we treat them in the neoadjuvant setting, we have the opportunity, if they have residual disease, to potentially even further improve their outcomes by giving them adjuvant systemic therapy. I also want to highlight, when we're thinking about adjuvant systemic therapy for residual disease, for our patients that have germline BRCA1 or BRCA2 mutations, there's also the potential opportunity to consider a PARP inhibitor. This is based on the Olympia clinical trial, and you can see that, of course, patients that were triple negative, treated with neoadjuvant chemotherapy and did not have a pathologic complete response, had the opportunity to participate in this study that randomized patients between olaparib, 300 milligrams twice daily for 1 year, versus observation. And this is data that Judy Garber just presented at San Antonio this past year. This was updated data. Of course, we had seen this previously, but now this is the 6-year analysis, demonstrating a substantial improvement in invasive disease-free survival at 6 years, an absolute difference of over 9%, as well as a substantial improvement in overall survival, an absolute difference of over 4%, favoring the use of olaparib. So case number 2, so this is a 63-year-old female with hypertension, undergoes screening mammogram, identifies a suspicious 0.8 centimeter density in the right breast, for which further diagnostic imaging is recommended. Ultimately undergoes diagnostic imaging, confirms this 0.8 centimeter mass at the 11 o'clock position, and a core biopsy identifies a grade 3 ER negative, PR negative, HER2 1+ negative breast cancer, and the right axillary ultrasound is again unremarkable. So this is a patient who would most often proceed for upfront surgery, I think appropriately. And the final pathology here is consistent, right? This is a T1B N0. I think this is the patient where adjuvant chemotherapy certainly is going to be considered and discussed. ACT would be an option, TC would be an option, as we discussed. But I actually want to talk a little bit more about this situation, which is something that I think we get a lot of second opinion consults for in clinic. What about the patient who looks like they have a T1B N0 clinically, and they go to surgery, and the final pathology shows that they've got 1 out of 2 sentinel nodes that has 0.3 centimeters of disease? And so the dilemma and the question that I think is often posed is, if the nodal involvement had been recognized at diagnosis, that patient would have been recommended for neoadjuvant chemotherapy and immunotherapy. So what do we do now that they're sitting in our clinic after the fact? So I just thought it was a good opportunity to remind us of the limited data that we have looking at the use of adjuvant immunotherapy in patients that undergo upfront surgery for triple-negative breast cancer and subsequently are found to have higher risk disease than maybe what we appreciated at diagnosis. This is data from the Alexandra Impassion 030 study. These were all patients, again, who had upfront surgery, and they were randomly assigned to chemotherapy plus atezolizumab versus chemotherapy alone. And this clinical trial showed that there was absolutely no difference in invasive disease-free survival, whether it was in the entire intention to treat population or the population of patients that was PD-L1 positive. So the conclusion of this study was that there was no benefit to adjuvant atezolizumab. We also, just at last year's ASCO, saw data from the ABRAVE clinical trial. Now, I think the patient that I referenced here was not well represented in this trial. So if you look at these patients, the vast majority of patients in the ABRAVE clinical trial were actually treated with neoadjuvant chemotherapy. They then went on to surgery, and then in the adjuvant setting were randomized to either avelumab or observation. Only about 18% of patients included in this clinical trial actually had upfront surgery, and then as a component of the adjuvant systemic therapy were randomized to chemo-IO versus chemo alone. And what we saw from this was that there was a non-statistically significant improvement in disease-free survival, maybe slightly favoring the avelumab, and then a very subtly statistically significant improvement in distant disease-free survival and in overall survival favoring the avelumab. But again, I really want to caution us here because these are, the vast majority of patients included in this trial were not the ones who actually had upfront surgery. And I think one of the reasons that it's been postulated that maybe adjuvant immunotherapy is not going to have as much of a benefit is that the presence of an intact tumor in the neoadjuvant setting may be very, very important to actually generating some form of anti-tumor immunity such that the immune system can have a robust reaction to the tumor. So again, I think at present, there is no robust data to support the use of adjuvant immunotherapy in high-risk patients who undergo upfront surgery. And I think in this case, we are still in the place where we are recommending adjuvant chemotherapy, typically with our gold standard ACT regimen. But again, I just wanted to highlight that case because I think it's a common second opinion we get of, I sent the patient to surgery, now they have nodal involvement, should I give them immunotherapy after the fact? And I don't think we have robust data, at least at present, to support that. So again, just some concluding thoughts. I think for T1A N0 disease, I think it is reasonable to defer adjuvant systemic therapy. These patients generally have exceptional outcomes and low likelihood of recurrence. I think in T1B, you're considering adjuvant chemotherapy, but probably likely limited benefit from anthracyclines. In T1C disease, chemotherapy is definitely warranted, and I think these are the patients when you think that they're good chemotherapy candidates, it's very reasonable to consider the administration of the chemo in the neoadjuvant setting so that you have the opportunity to give subsequent adjuvant systemic therapy if those patients have residual disease. ACT really remains our gold standard. I think docetaxel carboplatin, the data that we have suggests that it may be equivalent, but the data is limited to date, and we still await further studies that are more confirmatory of that. I think one of the other sort of tempting scenarios where we may consider this is in patients with germline BRCA mutations where they may have increased sensitivity to platinum. And I also think docetaxel cyclophosphamide ×4 is reasonable for lower risk disease or those with contraindications to anthracycline. And then finally, as we've stated, no current role for immunotherapy in T1 N0 disease. And that's my last slide. Thank you.
Thank you, Dr. Cobain. We'll probably save questions for the Q&A panel session.